the Egyptian Orthopedic Association and Benha Orthopedic course for giving me this opportunity. It's a very well conducted course. I bring greetings from India. I thought I'll present this case because this has a lot of findings in it, and it'll be an interesting case for discussion. It's a congenital case of congenital deficiency of ACL and bucket handle meniscal tear in fibula hemimelia, along with some deformities in the lower limb. So fibula hemimelia is a congenital deficiency where part of the fibula bone is hypoplastic, dysplastic or aplastic associated with hypoplasia, dysplasia of the tibia, and hypoplasia, dysplasia or aplasia of parts of the foot. It's basically a longitudinal deficiency, and incidence is between 7.4 and 20 cases per million live births. So this case report I have partially published in the Journal of Arthroscopy and Joint Surgery as a basically as a medial meniscus tear with congenital deformity. The deformities have not been mentioned in that. This is basically a 22-year-old lady with a 2-year history of knee pain. She had 1 year ago acute pain in the knee, which was treated conservatively. She presented to me with severe pain for 1 week prior to the presentation. So on examination, there were no systemic problems. Right lower limb was in valgus. Right knee was slightly lower compared to the left on standing. She had splayed 4th and 5th toes, and right foot was smaller than the left. The foot deformity itself, splaying of the 4th and 5th toes, the deformity was rigid, not correctable. There was no neurovascular deficit and no ankle instability. On clinical examination of the knee, there was 2+ Lachman, anterior drawer and pivot shift. Rest of the ligaments appeared to be intact. She had painful movements, especially full flexion of the knee. X-ray of the lower limb, this is basically a CT scanogram view, shows valgus deformity of tibia of about 5 degrees originating from the shaft, blunting of the tibial spines, no major hypoplasia of the lateral femoral condyle, although it appears slightly underdeveloped compared to the other side. There's absence of the 5th metatarsal. The 4th metatarsophalangeal joint was shared by the 4th and 5th toes, and 4th and 5th toes, proximal phalanges were fused at the base. The ankle appears normal. These are full leg views showing valgus alignment of the tibia with a center of rotation angle around the shaft of the tibia. MRI of the knee shows a tear of the meniscus, medial meniscus. This was actually a bucket handle tear of a horizontal cleavage tear. I think she must have sustained 1 year ago a horizontal cleavage tear of her meniscus, which has recently bucket handled, and that's why she presented with pain. So the plan was to take care of her immediate problem, which is acute knee pain, which needs a meniscal repair, and she has an unstable knee. The knee needs to be stabilized. The plan was to do an ACL reconstruction to protect the repaired meniscus. At a second stage, the deformed tibia to be corrected using an osteotomy, and correction of the splayed toes, because it's a bony deformity that needs correction as, with an osteotomy as well. So on stage 1, under examination of anesthesia, you can see that there is a positive Lachman, positive anterior drawer, and positive pivot shift. Diagnostic scopy showed a horizontal cleavage tear of the meniscus, of the medial meniscus. The joint surfaces are intact. You can see the intercondylar notch here The notch area also has been covered with pristine articular cartilage. There's no sign of footprint of ACL there. That's the bucket handling of the meniscus. The cleavage tier part of the meniscus has bucket handle and displaced into the joint. So that was reduced. The torn sides were debrided. This is again view of the intercondylar notch. The lateral side appears to be folded slightly, but on the lateral femoral condyles, there's no attachment of the, there's no evidence of ACL there. So medial meniscal repair was done using 5 stitches from front to back, using meniscal menders. Outside-in technique was used. The suture is passed through the metal loops and pulled out to the outside. And the free everted edges of the torn bit of the meniscus were debrided. And then all inside ACL reconstruction was done. She had her pain settled, and at 3 months following the first surgery, she had a corrective osteotomy of the tibia. An osteotomy was done at the center of rotation of the angulation of the tibia with a fibular osteotomy. A circular frame Ilizarov fixator was applied, and correction was done. She also had a closed wedge osteotomy for the deformity of the toes and fixed with K-wires. This is about 2.5 months following correction of her angle within the fixator. This is after removal of the fixator. Unfortunately, there was a little bit of propagation of the osteotomy proximally, so we delayed the distraction. She went on to heal. This was correction of the toes, and this is the clinical photograph after correction of the toes and correction of the deformity of the leg. That was pre-op, and this is post-op. So coming on to discussion, fibula hemimelia is classified according to Dror-Paley, Birch classification, and Ackerman-Kalamchi classification. Our case falls in the type 1 category. There are multiple deformities and findings associated with fibula hemimelia, and these could be a short or normal fibula, valgus tibia, aplasia of the cruciate ligaments, ACL and PCL, dysplasia of the tibial eminence, narrow intercondylar notch. Actually, the notch in our case does not look too narrow, so I didn't have to do a notch plasty for that case. Dysplasia or hypoplasia of the lateral femoral condyle, hypertrophied meniscofemoral ligament, a ball and socket ankle joint, anteromedial bowing of the tibia. In our case, it appeared just a lateral bowing of the tibia. There was no deformity of the tibia in the coronal, in the sagittal plane. Aplastic metatarsals, toe abnormalities, and limb length discrepancy. So ACLR in isolated deficient knee is controversial. There are reports of conservative management for an ACL deficient knee, congenital ACL deficient knee. and there's no evidence of ACL deficiency and meniscal injury. There are a couple of reports, only case reports in the literature. One where I think meniscus was partially, meniscectomy was done, because this report was from 1982, and the other recently, details were not given. Meniscal injury requiring surgical repair in the ACL deficient knee should be treated with repair accompanied by ACL reconstruction. This is for regular ACL injuries and not for congenital, but we need to stabilize the knee joint. The determinants of surgery for congenital deficiency are age, symptoms of the patient like pain, falls, instability, deformity like shortening, limb length discrepancy, malalignment, sagittal or coronal, and tibial slope. Dislocation and instability also is an indication. So the options available for ACL deficiency are conservative. Most of the cases are treated conservatively, especially if they are not symptomatic. And other option is to do an ACL reconstruction using extra-articular tenodesis, especially where the physis is not closed, and where there is ACL and PCL deficiency with an unstable knee. You could do a reconstruction. The tibial slope is altered. Limb length discrepancy needs limb lengthening or epiphysiodesis. Angulation of the joint line of the knee would require a femoral osteotomy, and bowing of the tibia would require a corrective osteotomy of the tibia. So to summarize, the regular principles of management for such cases would be to correct deformities first and ACL reconstruction later. Only in cases where there is meniscal tear, a bucket handle tear, you would need an ACL reconstruction and a meniscal repair as done in this case, followed by correction of deformities. Thank you very much.
Thank you so much, Dr. Servinas, for this very interesting talk. I think this deserves to be a case report.
Well, I have published part of it as a case report, actually.
Yeah,
I've done the full, after correcting the deformities, probably I need to add that to that case report.
Yeah, our moderators for this case, Professor Muhammad Shafii and Professor Muhammad Gouda.
Regards and congratulations for this case. It's definitely a case report. I've never seen something like this. I may probably ask, how can we suspect or diagnose what are the hallmarks of congenital ACL deficiency?
Congenital ACL deficiency is commonly seen with fibular hemimelia. One of the commonest causes is fibular hemimelia. The other one is proximal focal femoral deficiencies. These two are major conditions associated with congenital ACL deficiency that are reported in the literature. There are, of course, other causes like Larsen syndrome and a few others. Isolated congenital ACL deficiency is very rare, actually. And when ACL is deficient, we should suspect deficiency of other ligaments and other structural changes within the knee joint as well, like PCL deficiency. They have been reported that the meniscofemoral ligaments get thickened because in order to compensate the lack of ACL, it seems the meniscofemoral ligament gets thicker. There may be a very narrow intercondylar notch, in which case they say, that's one of the main reasons they don't do ACL reconstructions, because you need to do an extensive notchplasty in order to do an ACL reconstruction. The other reason is they could have hypoplastic lateral femoral condyle, in which case, the normal mechanics of the knee joint are altered. So we don't know where exactly the footprint of the ACL is. So we're not sure how much it will be helpful. Although there have been cases reported for ACL reconstruction following congenital deficiency, and they have done well. My case is now 2 years following all the procedures, and she's doing very well. There's no complaint.
Thank you, Professor Srinivas, for this very interesting case. Actually, I was very impressed by the plan you put for your patient and the steps you manage in these two major steps. Actually, you have a very big challenge here. It is the landmarks of the tibial attachment and the femoral attachment, and still, as you mentioned now, the narrow notch. I think these three challenges were, it needs an expert like you to manage it. Would you please explain to us what did you do to, or how you plan for the femoral attachment, especially femoral insertion, you know, of the graft?
Well, for the, as you said, actually one of the other common features in ACL deficiency is a blunted tibial spine, actually. And tibial spine, we can, you know, when you inspect in the knee joint, you can feel it. You'll be able to identify, and you can identify the tibial footprint for the ACL. On the femoral side, I went, because she did not have much of hypoplasia of the lateral femoral condyle, and the notch was not narrow compared to some of the case reports that I have seen in the literature. It's really narrow in those cases, but in this case, it did not look that narrow. So for the femoral tunnel placement, I chose a point from taking from the articular cartilage, from the posterior articular cartilage of the femur. And we have to go by the clock placement for the femoral side.
9:30.
Sorry?
9:30 o'clock?
Yes, around 10 o'clock.
Did you do a notchoplasty, please?
I did not do so because the notch did not appear too narrow. And when I was mobilizing the knee joint, there was no impingement of the graft in the notch. So I did not have to do a notchoplasty.
Okay, can I have some of your experience about the notchoplasty? We have a challenge here, especially 20 years ago when we started to do an ACL reconstruction, to do or not to do a notchoplasty. You know, this was a challenge someday. What do you think about a notchoplasty and when to decide to do notchoplasty? As we finished at the end of our experience, we said that we will not decide for notchoplasty except at the end of the operation if there is an impingement. Okay, before doing this, do you expect that a very narrow notch is a need for a notchoplasty, whatever it's impinged or not?
I think a narrow notch probably means the development of the notch is not well. So, you know, after you do an ACL reconstruction, if it impinges in the notch, then you would need to do a notchoplasty. Otherwise, the graft failure rate increases. I don't do notchoplasty regularly because for all my ACL reconstructions, I don't do notchoplasty. And even some of the experts, most of the experts nowadays don't do notchoplasties.
Yes, me too. I don't do notchoplasty, but I wanted to know your experience. Thank you. Very interesting case. Thank you. We learned too much.
Dr. Muhammad, Professor Hisham Al-Adi has a question to Dr. Srinivas. Okay. Professor Hisham?
You can join.
Professor Hisham Al-Qadi?
Please, Professor Hisham, join us. Professor Srinivas, Professor Hisham is one of our eminent professors in the arthroscopy in Egypt.
Okay, sir. Hello, sir.
Professor Hisham? هو muted? دكتور هشام.
هو دكتور هشام بس يفتح المايك حضرتك.
دكتور هشام.
طيب.
Thank you, Professor Srinivas, for this case.
Okay, Dr. Hisham.
May I have a question? I think it is better to correct the deformity concomitant with this case with upper tibial osteotomy to be fixed with a blade. This will allow us for two purposes. First is to play with the tibial slope, which you may prevent re-injury of the ACL, this precious ACL, which is all congenital, and then we have reconstructed it. So the tibial slope will help to protect this one. And if we have an osteotomy fixed with plate, we will, of course, will have an accelerated healing that will be equal and suitable for the accelerated post-operative rehabilitation for the ACL. This will give us a better healing, I think, faster rehabilitation than the laser off. What do you think, please?
Well, I thought about that actually, whether I can do everything together. But because the center of rotation of angulation was distal in the shaft of the tibia, I wanted to correct it where the center of, where the cora is basically. So I went for correcting the angle at a later date rather than on the same day. So that was my thinking, and also the other reason was tibial
Did you do
slope
the Elizaro by yourself?
Sorry, yes, I did.
Really?
Actually, I was trained in Elizaro during my post-graduation, sir, so I did it myself.
So you now we have an arthroscopist and Elizaro of man, okay, Professor Gamal. Okay, we may have this
Okay.
and we do it
Thank
here
you,
in
Professor Selvin. Thank you.
Okay, thank you so much, Dr. Servinas, for this interesting and rare case you present. From myself and the organizing committee, wishing you all the best, and to all our colleagues in India, and hoping to see you once again in Benha Orthopedic Review course as you was before with us. Thank you so much. Thank you, sir.
I'd like to thank Egyptian Orthopedic Association once again. Thank you very much, and Benha Orthopedic course. Thank you very much, sir.
Thank you so much, sir. Thank you. دلوقتي احنا معانا النكست كيس ان شاء الله.